you guys have to offer, the Medicare recipient, right? So when you're talking to a beneficiary, you're talking to a life client or potential life client, and you want to offer them some different services, or you guys want to help them in different ways, or even if they ask you, hey, do you guys offer Medicare? This is a good transition into being able to kind of assist your clients a little bit more. And not only top of that, this product obviously helps us cross sell too, right? We can cross sell sometimes if we can't get the final expense sale, or free up some money in the household. A lot of times switching to the Medicare piece, we may be able to find a product or products that kind of free up some money in the home and then revert back to the life sale as well. So the more products you have in the house, the better our retention rate is, and that's kind of the direction senior life is going, and we want to try to be able to provide as many products for you guys. I'm not saying you have to do it, but this is a good step into it. So you'll get a bigger picture. So I know a lot of you are doing AHIP right now, and you're doing ACT training, and I know a lot of that's like drinking out of a fire hose, right? So this piece, the Medicare piece, is going to tie all that in and kind of help it make sense, right? So we want to make sure that you guys have the three basic tools to know the road to the sale. Okay. So we'll start out with original Medicare. Obviously, Medicare can be entered into, you can join Medicare in the traditional way of turning 65. That's the initial enrollment period, which is called the IEP. Initial enrollment period is 7 months, 3 months before, the month of, and 3 months after their 65th birthday. They have that opportunity to choose to either go with traditional Medicare, Medicare supplemental insurance, or Medicare Advantage. We're going to talk about all three today because as you guys are talking to Medicare recipients or future beneficiaries, you're gonna have to know the Medicare basics, the option of a Medicare supplement, and then the option of a Medicare Part C. Okay, to kind of give them a complete overview of the cost sharing and all the things like that are going to be involved in original Medicare, Medicare supplement, and Medicare Part C, which is called Medicare Advantage. The second way you can that recipients can join original Medicare is under 65 is disabilities. Disabilities in original Medicare. If you have a car accident, right, you become disabled, you can go on Medicare Part A and B, and that's almost usually immediate for folks that are on disabilities. The second way is ERSD, end-stage renal disease.
I'm on my training.
Anybody has an end-stage renal disease automatically goes on Medicare Part A and B because they have to have life-saving treatment and life-saving care to be able to push forward in life, right? And that's expensive. So Medicare A and B, they go on Medicare A and B disability right away. The other routes are if I got hurt at work, I fell off a ladder, hurt my back, had a back surgery, and it's been kind of slowly progressing. And then I file for disability. Medicare will give them the ability to have Medicare Part A right away. And then they will put them on Medicare B in about 24 months. It takes 24 months for Medicare disability to take place. They got to go through that 24-month period. You'll hear a lot of people while you're in the field. Yeah, I've applied for my disability. I haven't gotten yet. It's taken forever. What a lot of people don't understand is they do have that 24-month wait period. And a lot of times they say, oh, well, I'm going to get a lawyer and try to get it quicker. And you can do that, but that's the process of 24 months, right? So traditional Medicare can be joined at turning 65, people on disabilities, children born into disabilities. We're going to show you guys today that Medicare is a moving target. Why Medicare Advantage is so important, and the cost of a Medicare supplement and the vast differences between those two entities and two choices that they're going to have, or three choices that they're going to have. And we're going to break Medicare down so you guys can kind of see what I mean by this is a moving target, and why a lot of your recipients or potential beneficiaries, why you need to roll it out to them this way, and why you need to talk to them in this manner. Because a lot of folks, agents, they come in, they're just product pushing. That a lot of them just, oh, this Medicare Advantage is the best one in this area, and this is what you should go with, Miss Jones, and boom, out the door they go. And that does not solidify a sale. That will not, you will lose your member probably every time if it's sold in that way. So we're going to break down Medicare so you guys can get a good shot of what it looks like and how it works. So let's go ahead and move on to the next slide. Medicare has two parts, Part A and Part B. Part A is obviously your hospital. This is going to be billed, and this is going to have in and out of hospital stays, okay? Part A has 150 days available to them, and this starts the date of their Part A services. Now, Part A can be, as long as you've had 10 working quarters throughout your working life, as far as the first time you got a job and started paying into Medicare, paying the federal government, out of all of those entities that come out of your paycheck. We all see those at every single week or every couple weeks. This is paying into the system. So you can get Part A for no cost as long as you had 10 working quarters. Okay. So you'll see a lot of people in this scenario, guys, that are usually, maybe a lot of baby boomers these days are waiting till they're 66, 67, up into their 70s to take Medicare, or they're working as long as they can and they're in a group plan, right? So if they're in a group plan and they can take original Medicare Part A if they're in a group plan, which is your hospital. And if they choose to bypass Medicare at 65, as long as they have credible coverage to do so, they can bypass and say, hey, I don't want Medicare Part A and B. I got a group plan at my work. But you want to make sure, if you are talking to someone in that capacity, to make sure that they understand that it has to be credible coverage. So it has to be equal to Medicare or better than original Medicare coverage to what they call, quote unquote, credible. Okay. So as you're talking to a retiree, the group, and you say, some of them say, well, no, I'm just on Part A, and they have a group plan, they can do that without incurring a penalty. Okay. So Medicare Part A has 150 days, has co-payments and deductibles. The numbers that you see on the screen right now are different. These are 2 years old, and I left these numbers up here for a reason, to show you guys that Medicare is a moving target, to be able to explain to your client why it's important to do an annual review every single year, and why it's important to look at the costs of Medicare. You've got 10,000 people turning 65 every day for the next 12 years. That's not including people on disability, children born into the system that have disabilities. These are millions and millions of people going into this Medicare program every single year. And it's really good to educate your retiree every year on these numbers, because it does solidify why they have the product they have, right? If I talk to them about original Medicare and talk to them about all the costs and look at the plan that they currently got, and they go, oh, that's way better, I'm staying right where I'm at, right? So there, that you can kind of use this as a annual, kind of an annual, just lost my train of thought. And you can use this as an annual follow up with them and say, hey, these are the numbers this year, they'll change next year. So the deductible for days 1 through 60 are 1,340. The current is 1,556. So we can see that those numbers have increased in the last couple of years. The crazy thing about this is you can pay this up to 5 times a year, which is about $8,000 a year in the current number, right? So $1,556 that you can pay 5 times a year as you go in and out of the hospital. Now, if you've had Part A for a while, get later years into your retirement, and you've spent 61 through the 90th day, so you've already exhausted 60 days and you broke into the 61 through the 90th day, it used to be $335. It's now currently $389, okay, per day. And that's the responsibility of the beneficiary, right? And 61 through the 150th day used to be 670. It's now 778. Now, guys, these are called lifetime reserve days, right? Lifetime reserve days is exactly what it sounds like. You get 150 in hospital stays throughout your retirement as you are on Part A. After 150 lifetime days, the 151st day on, the beneficiary will pay all costs. So we can see already how we're explaining this to the recipient. They're looking at that going, wow, I would never be able to afford those numbers if I just had regular Medicare alone. So what we're doing is working up to the part of the selling the beneficiary on the part of, look, it's not worth having original Medicare A and B alone. And then we move on to the next one. So the second part to this under the hospital part, which is Part A, is skilled nursing facility, which is SNF. You're going to have a lot of folks that use these facilities in a manner of a knee replacement, shoulder replacement, hip replacements are very, very common amongst retirees. And Medicare will give them days 1 through 20 at zero cost. So if I had original Medicare in my pocket alone, I had a hip replacement, they're going to keep me in the hospital for probably 2 days for observation, or even a day for that matter. And then you will either move to the side of the hospital that has a skilled nursing facility attached, or it's usually pretty close to the hospital and transportation, right? So once you get there, what these facilities are really used for is pain management, making sure that the client is on the way of getting better. Like I said, it's skilled. So that means they have to be on the road of getting better. They get them up out of the bed, make them walk, do exercises. They do PT every day. They make sure they're eating 3 meals a day, they're hydrated, and pain management is being managed, right? So 1 through 20 days, and normally it takes 7 to 10 days in one of these skilled facilities for a hip replacement, a knee replacement, or some sort of shoulder replacement. After that, it's 7 to 10 days. And then they usually will send them home, because they will give them as much care as they can until they're able to move around on their own, pick things up, walk on their own, and then they send them home. But a lot of times there are complications 21 through the 100th day. If there's a complication, you fell, the hip's not taking, the knee's not taking, there's an infection, you'd have to stay a little bit longer. 21 through 100th day is a copayment of, used to be $167.50, and it's now $194.50. And again, this is skilled. This is not short-term care, and this is not long-term care. This is for folks that are going to get better. And after 101 days on, they pay all costs. So once you can hit a wall in a skilled facility within the first 100 days, to where a lot of stroke or maybe early on Parkinson's patient use these to kind of do their PT. But once they hit that 101 day on, they pay all costs. And most people don't do that. They'll either transfer to a short-term facility or a long-term facility at that point. And then they're responsible for all costs in those capacities. So these are the parts that a lot of seniors don't know, how Medicare works and why a lot of their plans may or may not be paying for these services, because they just don't know how original Medicare works. Because if original Medicare doesn't pay for something, most of the Medicare, all the Medicare supplements and Medicare plans don't pay either, because these are expensive parts of Medicare. So as we're talking and doing a education for our seniors, these are really important points to come up to kind of really solidify why you are there helping them, and why you want to put them in a better position, and why their benefits matter. Okay. So Medicare Part B is the second part to Medicare. Medicare Part B is services outside of the hospital. These are your doctors, your specialists. They do pay for some in-hospital stuff like durable medical equipment, things like that. But there is a premium and a cost to Medicare Part B. Medicare Part B used to be $134 a month. It is currently now $170.10. So as you can see, it's gone up. The deductible Medicare Part B is fairly simple in explanation. It has a 1-year deductible of it used to be 183. It's now 233 annually. So as they're using their Medicare Part A and B, they'll have to satisfy an annual deductible of 233 and top of a 20% coinsurance. The biggest thing that most people need to know, if I'm looking at the option of regular Medicare and getting a prescription drug with it, is there is no cap or out-of-pocket cost to original Medicare. You can pay thousands, hundreds of thousands of dollars to original Medicare in a calendar year, and they don't care. There is no $5,000, $10,000 out of pocket, and then Medicare goes, "Oh, Miss Jones, don't worry, we'll pay the rest." Right? They do not. They will pay all the way up to these maxes, and 20% co-insurance as far as they'll let them pay. So knowing that, the leading cause of bankruptcy amongst retirees is this right here, medical debt. They cannot afford co-payments, deductibles, maximum out of pocket. They can't afford all of this stuff. So understanding and laying out that this is an option, and you do have your choice at the end of my presentation to have regular Medicare alone, a Medicare supplement, or Medicare Part C, right? So we obviously know that any person you're talking to with any kind of sense will say automatically that Medicare A and B is not a viable option for them, even if they don't have the money to pay the $170.10 for the Part B premium. And we'll talk about that here in just a few minutes. So Medicare Part D covers prescription drugs, obviously. During that initial enrollment period, a beneficiary must have a prescription drug plan in retirement if they are Medicare eligible. If they do not have a Medicare prescription drug plan, Medicare will penalize the beneficiary 1% a month every single month they do not have one. So that's 12% a year of the average annual drug cost. So as the drug cost goes up, the longer they go out without a drug plan, Medicare will penalize them without a prescription drug. You'll hear this from a lot of the baby boomers more than I heard it 10 years ago. Oh, I'm healthy. I take herbs. I take supplements. I don't like prescription drugs. I will never take a prescription drug. And you can say that's fine and good, Miss Jones, but you have to have a prescription drug plan attached to your original Medicare or your Medicare supplement or Medicare Part C plan, or you will be penalized. Also, Medicare prescription drugs, CMS sets the standard every single year on prescription drug. What that means is they set a cap. I think this year it's around $4,000. They will allow a beneficiary to spend until they hit the donut hole. You'll hear a lot of people out there that take a lot of prescriptions hit the donut hole, right? So that means between January when their plan takes effect and the next calendar year when they can get a new plan, if they spend, let's say in June, they spend $4,000 between January and June, they will go into what they call the donut hole. The donut hole, that means that their cost of prescription drugs will go up and they will pay almost full cost for prescription drugs until they hit a catastrophic phase within the Medicare prescription drug plan that's built in for the person in the donut hole. Now, if they hit this catastrophic phase, they have spent the maximum amount of money in the donut hole to hit the catastrophic phase, to where now the Medicare or federal government will start picking up majority of the cost for prescriptions. But I will tell you guys, between the time they hit the donut hole and the catastrophic phase, they can spend tens of thousands of dollars on prescriptions before they hit the cat phase. And I'm going to tell you, a lot of them go without insulin. They go without a lot of their diabetic medications. They go without heart medications, inhalers that are super expensive. They'll go without this stuff until they hit the catastrophic phase, or until they can get another Medicare Advantage plan, which is very unfortunate. So that's why we want to make sure that the beneficiary understands all of these in and outs of Medicare, and that they understand Medicare is a moving target, and you have to abide by the rules in traditional Medicare and outside of it in the private sector, so you don't get in trouble through the calendar year. Also, the 1% that is assessed if they choose not to go with a prescription drug, that is for the rest of their retirement until they are no longer on original Medicare. Once the penalty is assessed, it never goes away. Okay, so we want to make sure that we give them a good education and make sure that they understand a prescription drug plan and how they work. Okay. So let's move on to Medicare supplemental insurance. A lot of this, guys, I know we're not offering Medicare supplement to date, but hopefully after January 1, we will be offering Medicare supplement. And this will be a viable option for us to be able to offer them right now. But this piece of it is for you guys to be able to talk to it, right? I want to talk to you, Ms. Jones, about Medicare supplement. And I want to talk to you how it works, because this is one of your options. Medicare supplement, you'll hear sometimes is referred to as a Medigap policy. It does exactly what it says. It supplements all of those copayments and deductible that we talked about in original Medicare A and B, or it covers the gaps in Medicare A and B. Okay. Now, these plans from A to N is what they have available to them to cover those gaps or supplement in Medicare, original Medicare, at different costs, right? So if you have a healthy senior that says, hey, I rather would take a cheaper plan, maybe a plan B, a Medicare supplement plan B that covers 50% of those gaps, I can do a little cost sharing and I can pay as I go. They have the option to look at plans A to N, right? But as you're looking at these plans, the biggest thing that you need to understand is the federal government standardized these Medicare supplement plans back in 1996. They did that to simplify the options. So if you're looking at company X and you're comparing it to company B, just know if they pick a Medicare supplement plan G, right, it's the same exact plan for every single company that you have, as long as you're comparing apples to apples, right? So a plan G is the same plan with every carrier out there, no matter who they are. Okay. CMS is the one that decided that the benefits are the same in each and every one of these plans, no matter what company you're using. Okay. The only thing that's going to confuse the retiree and some of the newer Medicare folks that are selling this stuff is that the premiums are different. You might have $105 a month premium for Plan G, and then another company has another or $86 for the Plan G, and you're looking at those going, wow, the $105 one's more expensive than the $86 one. I'm going to go with the $105 because it's probably got more benefits. That's not the case. They're all standardized throughout the Medicare supplement hierarchy, right? So we want to make sure that the clients understand, hey, you got options. You got to be Medicare supplement is an option. Medigap policy is an option, but you do have to pay a monthly premium for the Medicare supplement. The average Medicare supplement for a male turning 65 is about $110 to $120 to date, right? So now we're looking at, I have $170.10 a month for Medicare A and B, right? And then I've got around $120 a month for my Medicare supplement. It's starting to get a little expensive, right? We're looking at it going, well, man, I only get about $1,500 a month in Social Security. I got a little bit of a pension. And guys, you'll see a lot of seniors don't make more than $100 or $1,500 a month in Social Security. That's on the higher end. A lot of them are well under that without some sort of pension or supplemental income to increase it. So most seniors live off a very, very fixed income, and their Medicare premiums and their Medicare supplement premiums, or even Part C, is at the top of the list of their budget. So when you're talking to someone about putting on a final expense or buying another product, and you talk about their Medicare is their number one in their budget, and everything else comes below it, right? So if I can save them some money in this sector and free up some money in their household, I may be able to transition some other stuff within their budget. I might be able to get my final expense plan within their budget, right? So this stuff is really important to know when you're cross-selling or offering someone another product. And what is so attractive to a senior with the Medigap or Medicare supplement is there's no networks, right? You get a lot of seniors that get hung up on this because they didn't get the proper education. Okay. No networks is to me is not that big of a deal in the Medicare space and in the Medicare world, because the Medicare space has the largest networks in insurance, period, throughout the country. What they try to compare these to is group plans with networks, right? If I have a group plan with company X and I've had my group plan for 20 years, that group plan with that company, their networks are very small because it's just with one company, right? When you move over into the Medicare space and you're looking at Medicare supplement or just traditional Medicare or Medicare Part C, the majority of hospital and doctors throughout the country have a large network for Medicare and Medicare Part C. Almost all the hospitals and doctors take a Medicare Part C, or all of them take Medicare, original Medicare. So no networks, they get all frazzled about that or excited about it because they had that agent maybe come in and really sell that point and only give them that option, right? They've never heard any other option. So networks makes this thing, no networks makes this thing really attractive. And then you say, oh, there's no referrals either. You don't have to get a referral to go see another doctor. That's what gets them to pay this larger premium, because they literally didn't get very good education on what their options are. Guaranteed issue at T65. So when someone is turning 65 and they are in their initial enrollment period, they have the ability to choose one of these Medicare supplements with no health questions asked. So as long as I apply to a Medicare supplement within my IEP period, that's 7 months, the insurance companies cannot ask me one health question. That's your one get out of jail free card in retirement, right? So we want to make sure if this is a viable option for them and they do have some health issues, that they can go to a Medicare supplement without being underwritten. And they cannot kick them out, or they cannot increase their premiums because of their health or how often they're using it. That's a CMS guideline. So a lot of these plans have zero copays, zero coinsurance, and it's 100% of coverage of what Medicare doesn't pay, or paying those gaps. That is an option. But depending on what plan you choose, you could have some copay and coinsurance depending on what type of plan that you're going to go on, right? So this particular option, you'll have original Medicare, the Medicare supplement, and your RX card. You have to buy a standalone prescription drug plan in your or you got to add it to your Medicare, your Medicare. It's got to be another option, right? A standalone prescription drug with whoever you choose. So you have three cards that you have to show at all times. Medicare will always be sent the bill first because they're the primary. And as long as the doctor accepts assignment and says, yes, we take original Medicare, the Medicare supplemental insurance cannot itemize. They can't say they're not going to pay for something. That's the part of a Medicare supplement they sign into a contract with Medicare, original Medicare, stating whatever Medicare approved charges, whatever they pay and send on to the supplement, depending on what plan they choose or got in their pocket, they have to pay the remainder. And also, Medicare supplement will not pay if Medicare doesn't pay. A lot of people ask me that question. Well, what if my Medicare doesn't pay? Will my supplement pick up my co-payments? They will not. Medicare's the primary, and Medicare has to pay first. Doctors do not care who your Medicare supplement is. That's another key point why Medicare supplement is is attractive, is because doctors don't care who. There is no network to the Medicare supplement. They are a secondary payee. So that means if Medicare pays, the supplement will pay later. So if I have three cards, I've got $170.10 for Medicare, about $120 for my Medicare supplement, and around $27 to $55 for a prescription drug card. Guys, that's a lot of money. So if you have two members in a household paying almost $300, I mean, that's $600 a month just about coming out of someone's Social Security, on top of a rent payment, a car payment, gas, food, all of these things that are obviously inflated in our current state right now, right? This option is very expensive because Medicare Part Premium can go up every year. Your Medicare supplement will go up every year. That's a fact. As you age, Medicare supplement increases their premiums around 3% a year. RX will vary from year to year. They want to shop that every single year during the AEP. The biggest thing is, I usually, if someone goes this route, I have probably a little under 5,000 clients on a Medicare supplement or a Medicare Advantage product. I had about 26% call me last year and switch to a Medicare Advantage because in the third year, their Medicare supplement has went up to the point to where they just can't afford it. And then when I presented the Medicare Part C again, they looked at it, compared it, and said, gosh, this is really a no-brainer. I want to move over to this side. Okay. So just know we're talking about this because you have to be able to talk to it to compare. And if you do, guys, if you talk to them and compare these three as you're selling the Medicare Part C, they'll get a 30,000-foot view of this thing, of their options, and go, man, this is just the expensive route, and I don't want to pay all this money. And you will sell it without even selling it. Giving these three options to them, you'll sell the Medicare Part C without even going into in depth on what Medicare Part C actually covers, which is pretty wild. Because if I start talking to them about their third option, which is Medicare Advantage, which is known as Medicare Part C, right? So we've talked about A and B, original Medicare. We've talked about the gaps that you can cover with a supplement. These are very attractive for retirees that are, number one, very healthy. Like I said, they don't want to pay for insurance until they have to use it. They don't want to pay for a prescription drug because they don't take drugs. So in this particular option, I can get a prescription drug plan. I can get a plan to little to no premium. So all I'm having to pay is my Medicare Part B, $170.10. Now, you do have to have Medicare A and B still to go to the private sector, which is Medicare Advantage. You have to continue to stay on Medicare A and B. That is a CMS guideline, and they must maintain that Medicare Part B premium and maintain A to have Part C. Okay. Now you'll hear a lot of your clients say, well, my last guy told me to throw it away. My last guy told me to put it in the safe. That's correct. 50% of that's correct. They don't need to, they can't throw it away, but they can put it in the safe because they don't have to use it anymore. Because in this particular model, Medicare or the private company, whoever they choose to go with, in our case, WellCare is the primary pay now. So every doctor, hospital will send all the bills to WellCare. WellCare will pay all of the bills and then cost share with the client in co-payments and deductibles, right? So this is a known insurance that is you pay as you go, right? So if I have to go to a doctor, a lot of plans have zero co-payments in my primary care, or maybe a low one in some areas like $5. My specialist could be $35, $45, depending on what zip code or area you're in. These plans will differ, okay, and cost sharing and co-payment. But the most attractive thing to the senior is I'm not paying for it until I use it. These plans are also really attractive to low income folks, low income, special needs people that have either Medicaid or some form of Medicaid. So there's 3 levels of Medicaid that you qualify for, which is QMB, SLMB, and those are different levels based on their income. Now, how we find out whether they are a recipient for a low income product or a disability product is, number one, a simple question is, hey, Ms. Jones, let me ask you a quick question. Are you on Medicaid by any chance? A lot of them will know. Some of them won't even know. But how we find out, you say, hey, don't worry if you don't know. I can go into the Ascend app as I'm writing an application. I punch in the 11 characters on their Medicare card, and that's got numbers and letters, right? I punch that in, and it will tell me whether that recipient is what level the recipient qualifies for one of these, what they call DSNP plans, disability special needs plans, right? So we can always find out when we punch in the zip code and Ascend, it pops up all the different plans that are available to them. And then it'll send us to the next step of saying, hey, do they qualify for low income subsidy? Punch in the number, it tells you the exact product that they'll be available for them in their area. Another attractive part to Medicare Part C is they have maximum out of pockets. It's called a MOOP, maximum out of pocket. You'll hear that slang, thrown around in the Medicare space, which that means in the calendar year, if I'm comparing a Medicare supplement, right, with original Medicare to a Medicare Part C, their maximum out of pocket or their premiums that they're paying for original Medicare and a Medicare supplement usually will come around $4,000 a year that they're paying for premiums without even using the insurance on the Medicare supplement side. I can switch them over to here and say, Ms. Jones, listen, I can get you a 0 premium plan. Your maximum out of pocket equals to what you're already spending, right, in co-payments and deductibles, and you won't even pay that all at one time. You'll pay it as you use it. So that's the attractive part about the inner workings of a Medicare Advantage is they have little to no co-pays and deductibles within the body of the plan. And they also include, many of them include prescription drug. So I have a Medicare Advantage, which includes Medicare A and B, my hospital and doctor, and it also includes my prescription drug at 0 cost. Guys, I'm going to tell you, in this atmosphere today, 48% of the population is on a Medicare Advantage to date and rising, because these particular plans on the Medicare Part C side are getting better and better every year as we go. These companies are very competitive between each other as far as their plans, and they're competing for beneficiaries. So these particular plans, a lot of folks on the Medicare supplement side will also have a hearing, vision, and dental plan attached to their Medicare policy too, on the Medicare supplement side. So they'll have four standalone plans: Medicare, Medicare supplement, prescription drug, and hearing, vision, and dental. These plans have everything wrapped into one, because these plans also have hearing, vision, and dental attached to them, that at no cost until they use it. So as far as repurposing dollars, and as you guys can see right here, if I can possibly free up $3,700 a month in a home from a Medicare supplement to a Part C, or even not only that, give them a low cost sharing from their original Medicare as they're using their Medicare every single month, they're going to the doctor. If I can lower the cost and repurpose that money somewhere else, I can solidify another sale or a cross sale, right? And tie Medicare to whatever product I sell them outside of that, which your retention rate for both will go up. Now, a lot of these plans in a lot of areas have multiple plans per zip code. What I mean by a lot of these plans are not sold correctly, and the simple fact is they're not given their options up front. So let me talk about a little bit about networks. So these plans have networks, right? They are made up of networks of multiple hospital doctors, things like that. How we find that out, and how we find out what the best plan for them is obviously our SIN tool. We type in the zip code, all of our plans pop up. Now, a lot of people in this space, or in the Medicare supplement space, were sold the wrong way, because they say, a lot of them that you have a lot of agents out here that just sell Medicare supplement, and they'll say, oh, you don't want that Medicare Advantage stuff because they have networks and it doesn't travel and all that stuff. And guys, that's simply not true. And as long as this plan is sold properly and it's presented properly, these plans do travel. Because if I have a Medicare Advantage in my pocket and I'm traveling down to Florida and I'm in a car accident and down in Florida, and they helicopter me to the local emergency room, all of these things are billed in network because it was in lieu of an emergency. Okay. Same goes for if I get down to Florida, didn't have an accident. Let's say I stepped on a stingray and they took me to the ER, or they took me to the hospital. It's all in network. Or let's say I'm down there and I get a cold. I'm starting to feel pretty bad. I probably need to go to the doctor. I got a high fever. The first place you go is an urgent care. You find the most local urgent care, walk into an urgent care. Any urgent care in the US with a Medicare Advantage charges a copay. It's like $45 for most plans. Go in there, get my prescription, get my treatment, and then I go back to my hotel, take my medicine, and then wait till I get back home to go to my primary care doctor. So these plans can be used out of state. They can be used traveling, as long as they understand how to use the plan. Okay. Now, how you can't use the plan if you're in Florida is I can't say, well, I feel bad. I look in, I Google on my phone, oh, Dr. Taylor's only 1 mile away. I'm going to go down to Dr. Taylor and just walk in his office and say, hey, I'm sick. Do you take my well care? I mean, he may be in network, he may not be, but that's not how you use the plan. Go to the proper facilities and use it in the proper way, and these plans will bill them just as such if they were in their own backyard. And that's the biggest disconnect between Medicare supplement and why people own a Medicare supplement. They're afraid of networks. Because they haven't been taught or given the proper education on one plan versus another. So as long as we lay it out this way and we have them look at the differences between the plans, this is an easy sell because it sells itself. So Medicare Advantage plans are for health. These plans do a lot of health networking for that original Medicare doesn't do, and a Medicare supplement doesn't do. Original Medicare and Medicare supplement, all they do is pay your bills. That's it. They don't give you free screenings. They don't give you all of this all the things that a Medicare Advantage does. Medicare Advantage motto is if we can catch a disease early, the least it'll cost us out of pocket. So if we catch a cancer early detection, early screening, I'll probably be able to save your life, and it's going to cost us less to do it. If you don't catch it early, some of the caveats to that is now we're just going into life-saving mode, and it's going to cost us millions and millions of dollars to potentially save your life. Medicare Advantage promotes health, so that's why they give you a free OTC per quarter. That's over the counter. They want you to take. They're promoting you to take your vitamins, get heart monitors, Fitbits. There's all kinds of things in the catalog that they can get. And here in North Carolina, that's a $450 a quarter benefit that they can spend every single quarter just on their health, just on you kind of like, vitamins and things like that. And a lot of seniors take vitamins today. And that will vary from zip code to zip code, state to state, right? You just got to look up the plan and ascend. The also great part about this is hearing, vision, and dental they have to offer, also along with flex cards. WellCare has flex cards in many states and many zip codes that we sell in that give them, if Miss Jones has never had designer frames, she's got a flex card to where the vision part of the plan paid so much, and then WellCare gives them a flex card to pay for the designer frame up to so much, right? And you can use that flex card on the hearing, vision, or dental part. So if you've got a lot of folks with dentures, things like that, they have the ability for the plan to pay, and then the flex card pay the rest. And that is also, if you punch in a zip code, it tells you exactly what those are in each state. The Medicare Advantage also has wellness programs. That means they can go to a gym. They can have gym memberships at the Y or your local gyms. Most of your local gyms now take the Medicare Advantage silver sneakers or whatever they want to call it, the gym membership, which is normally about $35 a month in savings for them, to where they can go walk and use the pools and things like that. Those are added benefits to be able to offer a retiree. And if you're comparing plan to plan, a lot of what sells WellCare, guys, is the hearing, vision, and dental, the OTC, and the food cards. Food cards and those, a lot of these Medicare Advantage plans in the meat and potatoes of the body of the plan, they're pretty close from company to company. And where a lot of them stand out is the hearing, vision, dental, OTC, food cards, and a lot of these extra stuff that they have to offer. We have a lot of plans that will give money back to their Social Security. It's called the Medicare Give Back, or the Give Back plan with WellCare. And they give $50 a month back, $70 a month back. And that's our job to find, Miss Jones, in your current plan, what do you see in your current plan you wish you had more coverage, or you wish you had more of, right? She may say, well, gosh, I wish I had more of that food card, or gosh, I just wish I had more money to my Social Security every month, or I wish I had more hearing and vision and dental. And a lot of times WellCare can surpass those expectations with those extra benefits and being competitive, right? So with the Medicare Advantage, we have one card. Medicare Advantage is prescription drug, hospital, and doctor. You show one card, in and out of network, and they will bill you co-payments appropriately. A lot of these plans have transportation attached to them too. What we're running into, a lot of seniors aren't driving anymore, or they can't afford gas, or they can't afford their insurance. So they're using public transportation, and a lot of these plans have some form of transportation, unlimited trips, 100 one-way trips, depending on what state, zip code you're in. the plans are going to vary from state to state. And folks, we will get into these state specific plans later this week and next week. We're going to do some product specific training with the local Rams in your area. And I will encourage every one of you to reach out to your local regional managers with WellCare. Each state has about 4 to 6 of them, depending on the size of the state. These folks are there to support you selling WellCare. They give you supplies, they'll give you support, they'll come in and do trainings for you. You want to do a training once every couple weeks or once a month, all through AEP. They're there to support our group, okay? So make sure that I will put in the chat my email address. Stephen, they do offer dual eligible. That's what we were talking about. These D-SNP plans. Actually, WellCare is the leading D-SNP carrier. All right, there we go. WellCare actually manages 30 states. They actually manage 30 states Medicaid programs, because obviously the states don't manage their own Medicaid programs. WellCare manages 30 states out of the 50 of Medicare programs throughout the states. They win most bids in each state to administer Medicaid. D-SNP plans, low income subsidy plans, they're the leading carrier. That's some of their best plans. If you do have a D-SNP plan, all of these benefits that we're talking about between hearing, vision, and dental, OTC, all of them are enhanced. They have a lot more benefit if they do qualify for a D-SNP. So that will also tell you in the lineup of what plan to sell them and how to be competitive. Okay, guys, that's going to conclude my spiel for original Medicare. But I will tell all of you guys, make sure that where we miss the boat on this stuff and why people don't stay with us, we have to make sure that we lay out the sale exactly in chronological order in this way. So number one, you're really not making a sale, you're educating, right? The education will make the sale for you in the very end when you present the Medicare Part C, because it just gives you so much more benefit and so much more money back in the home to repurpose in other stuff, for them to be able to kind of live a little bit, without on such a tight budget. And that's our main goal when we're out kind of educating folks and trying to put them in the right plan, is just make sure that that they've got as many services as they possibly can get, and they're getting every benefit they're entitled to in their area. And that's our goal. So we want to make sure and I'll say this and I'll close. If you guys end up selling a Medicare Part C and it's for the hearing, vision, dental, or whatever, what I do every Medicare Advantage sale, if you can get your customer to have a future date or use their insurance as soon as possible, and it pays for some of their benefits. So what I do when I sign someone up, I get their first OTC order coming. I'll have that order and they get excited about they're getting some goodies, right? The second thing, if I sold it on the dental benefit, I want to make sure I get them their dentist appointment set up for their future x-ray, cleaning, whatever they bought it for. Because the reason why a lot of these people will switch is because the agent sold it to them, run and gun, right? Slapped it on the wall and didn't assist them after the sale to be able to use it. Because if you get your clients to use this policy and they're getting their OTC and they're getting, their gym membership and all their card, guys, they will stay with you, and they will, answer their calls, answer their emails, their text messages, and make sure you help them. Because if you are selling this stuff, I will tell you, this is a service business. This is not like final expense. A lot of I've sold a lot of final expense in my career, and I know I get that premium. And there's a lot of times, guys, I don't ever talk to them again, and that's just the nature of the business. With Medicare Advantage, you will talk to them multiple times during the year. You'll talk to them every year, at least once during AEP, annual enrollment period, which is coming up between October 15th and December 7th. You may also talk to them again during OEP, which is open enrollment period, which is January 1st to March 31st. You might be reaching out or making sales during that time frame too. So as I said, I put my email in there. As you guys need help, you need an ear. If you're in a home, you don't know something, text me, email me. If I'm available, I will help you right away, especially in your home. Because guys, I'm one of you guys. I've been selling for 20 years, and I've managed agents for 20 years, and I know how it is to be in a home and not know an answer or wanting to need it to close a sale, right? So if you ever run into that scenario, you get caught in that jam, make sure you reach out to me or the local RAM or somebody. But I'll do my dead level best if you text me and say, hey, I'm in a home, can you help? And I'll either get on a call with you or answer it by text. So, hey, I thank all of you guys for being on here today. I appreciate you guys taking the time. Sorry for the rough start. It's taken a little longer. We've been on this thing a lot longer than we want to. And CMS or WellCare offers the ability to record phone calls. Stephen, that's called the rate system in Ascend. In our Ascend platform that we download to write applications, there's a what they call rate tool with the little headphones in there. You click on that and we give you your own 888 number or your 1-800 number, and you can make outbound and inbound calls for that. And so we'll, if you email me your NPN, and I think you may have already done that, your NPN, your email address, I can get you a rate number to be able to record all of your calls. Okay. So guys, again, thank you so much. I appreciate everything. I appreciate you guys being on here. Sorry for the delay. And I hope you guys, if there's any more questions, I can take some more questions, or if you guys are done, we'll wrap it up. So thank you guys. Appreciate it.
James, thanks a lot for being on here, buddy. And thanks for persevering through the technical difficulties we had. And thanks everybody else for being on here. That's going to conclude everything, and we'll talk to you soon.
All right, guys.